Thank you so much, Ms. Hayes, for coming and agreeing to talk with us about your counseling services that you provide to your clients. My first question, in your field, what are the most pressing social problems confronting your clients? And which target population do you work with?
That's a loaded question. Right now, the most pressing social problems that are confronting individuals, one is a lot of alcohol or other drugs, simply because of what has happened with people being closed in during the pandemic. They have been unable to cope in a healthy way, so they have transitioned to using either opioids or more alcohol, um, and any other drugs that they can get their hands on. That's one. Another problem that's been confronting most of my clients have been more so trauma from their childhood. So a lot of people do not sit with themselves. Most people try to be busy, busy, busy. And so again, during this time, they've been inside, not really socializing, and they've had to sit with their thoughts. And so therefore, a lot of the childhood trauma that they have suppressed has come up. The population I currently work with, I work with anyone from the age of 5 on up. I have a 9-year old on my caseload right now. I have like a 19-year old, 20, and then I have a lot of older adults and young adults, but my population is across the board right now.
Okay. What type of programs does your agency offer to clients with substance abuse issues? And what type of partnerships do you have with other health professionals to give your clients more support?
Well, right now, the agency I work for, our actual clientele is working with individuals who have been in accidents or incidents, or they have other mental health issues. And when I say other mental health issues, meaning other diagnoses from either bipolar, from borderline, anxiety, depression, and also AOD, which is alcohol or other drugs. The agency I used to work for not too long ago extensively only dealt with individuals who were struggling with drugs and alcohol. And so in that program, they had what we call medication assistance treatment, which they will issue Suboxone depending upon what drugs the individual was working to wean themselves off of. Um, and they had a nurse on site. And if our program at that time was not able to support everything, because some people are actually, they need a higher level of care. So where I was, we would be able to refer them to places like Loredak in Colombia for them to detox and have a stay. Or we can refer them to the Palmetto Center in Florence, where they are able to go for a 28-day stay for rehabilitation, and then come back out and participate in the outpatient programs that will help them maintain their sobriety.
Oh, okay. What type of support mechanisms does your agency offer to support their families, especially those who are addicted to drugs and alcohol?
Well, for us, like where I'm at right now, we do have resources and referrals within the area that we serve. So that just simply means that if someone comes and it needs to be family therapy, if we're unable to provide that, then we have other partnerships with other counseling agencies who's able to provide the family therapy, because that's needed when you're confronting an issue within the if it's just, if it's one person, then it's impacting the whole family. Other resources for children to get in therapy, because I have some of them who come see me because of what has happened with mom or dad. So there are other programs that we can refer out, and the resources that are available to help families get the help they need as far as with therapeutic things. If they need to see a psychiatrist, which would be the person to prescribe medication, then we have a partnership with psychiatrists and psychologists in our area in order to get them the right level of care.
What do you do with patients who have been through your program, but they relapsed?
For well, that's a individuals, and I'm going to base what you're asking me off of my previous job as a clinical counselor for a drug and alcohol facility. But the individuals who say they go to the rehab for 28 days and they get out, and then they may stay clean for a week and they relapse, what we generally will do, we will still work with outpatient and get them back into they have to detox first and then go back, but they only have up to 3 times, because what typically happens is that a person is forced into our treatment. And when I say forced, they have DSS, or they have like court, it's court ordered for them to participate in a drug or alcohol program. Most times people do not willingly walk into the doors. And so generally the first time it can be that the person would relapse because they weren't ready. The external motivation was why they got there. And maybe the second time they've gotten motivated internally to see the need that they got to get cleaned up for X, Y, and Z. So we give them at least 3 times. After the third time, then they have to wait a certain amount of time, between 60 to 90 days, before they can return back to services. In that time, we will refer them to other agencies that will be able to help them.
Okay. So my next question would be, because of COVID-19, many counselors and health professionals have had to change the manner in which they converse with clients. Have you implemented teletherapy, or what has your agency done in light of COVID-19
Oh
with
yeah.
serving your clients?
Um, it's we have a telehealth platform, and it's actually called doxy.me. So because of COVID, we have transitioned to telehealth, and thankfully, the insurance companies, they do pay for that service. Um, since we are confined, and being remote is protecting us and the individual. We do, like, I do go in the office maybe twice a week, because I have maybe 2 to 3 people that ask to be seen face to face. But of course, the protections are in place to ensure that we are social distancing, we have our mask, so forth and so on.
Talk me through your typical treatment plan from step one to when the client can exit through from a program.
Well, the start is an assessment, and the assessment is usually called a biopsychosocial assessment, and that can take about 90 minutes. And so we get the biology, the psychology, the social aspect of the individual, which means how they grew up, if they had any other medical diagnoses, their social interactions, if they're using drugs or alcohol, to determine what diagnosis we need to be treating. Once the assessment is done, uh, I clinically will have to write a general impression of everything. So that just means I have to note if they have any motor abnormalities, if they have, describing their affect, the way they look, the way they speak, if they're being guarded, if they're friendly. All of those things go into play as to the assessment. Once that's done, we determine the diagnosis or diagnoses. Then we develop a treatment plan around um, around the diagnosis. And the treatment plan can be anything to say, it really are the goals that we're looking to achieve throughout the process. Um, a person can be in service from anywhere to from 30 days to a year. It just depends, because some goals are a little harder to achieve than others, and some have some setbacks. So, for example, a goal can be, I want to get my kids back. And so, what does that look like? That means that I have to I have to have clean drug screens for the next 3 to 4 weeks. Um, I have to learn how to implement coping skills. I have to identify my triggers. So those are the different goals that will be listed based off of, say, someone with, I would say, alcohol addiction or any other AOD. So when the goals are reached, that's when treatment is, as far as we determine if the person is ready for discharge or if they need to be transferred to a higher level of care. If they've met their goals, then that's when discharge happens. If they have not, then the time is extended. We assess their actual how they've been in service, if they've been doing what they need to do, just had some minor setbacks. But that will be that's usually how it ends. From assessment, we develop the treatment plan with the actual client, and then we go ahead and implement the treatment plan. And then once the goals are met, that's when discharge happens.
Oh, okay, thank you. Now,
Mhm.
also, at your agency, do you work with children who have challenging behaviors? For example, do any of your clients have issues with bullying other children, or maybe they're homeless, or maybe they have temper tantrums in class?
Right now, I don't. I have, though. I've worked with children who have had to be removed from their homes because their parents have been abusing them. So, with that abuse, the kids started reacting in a certain way in school. And so, therefore, they were extremely aggressive. So, yes, in working with them, there's always a root to any and every action that we do. And so when you work with children, I mostly implement play therapy because that's the way that they communicate, that's on their level. And in talking, in doing play therapy, you just have different items that they can, you say, this is that. Tell me how you would take this ball and roll it to Sam on this side. If he picks up and throws the ball, you ask why. You have to ask a lot of open-ended questions. But working with individuals, working with children who come from an abusive home, typically turn around and go to school and abuse other people because of what they've seen.
Mhm. Now, my next question is, what advice would you give to new counselors and therapists who are coming into the field, as far as the do's or don'ts? Or
um, Definitely know the ethical standards, because you have some clients who are mentally not stable, who would want to cross that line, to want to call you when they want to call you, talk to you whenever. Don't do that. You have to set appropriate boundaries with them. Also, make sure that if you do not know, you have a supervisor for a reason. Reach out to them. And if ever you're uncomfortable with working with someone, let your supervisor know, because it is up to your discretion. You don't want to transfer anything to what we call counter transfer. If you're feeling a certain way, or if you're triggered by something, you don't want to counter transfer that to the clients that you're supposed to be helping. So if you know it's something that you're unable to do, by all means, tell your supervisor so that they can, take that client away. This is definitely a field that you have potential to make money, but money shouldn't be the goal. You need to really be an advocate to help individuals, because there are a lot of people who need this type of help.
how do you manage your time and your caseloads in the most efficient way?
Right now, the way that I manage my caseloads, well, we have an administrator who places people, but I have the discretion to move them wherever I need to move them. So I typically, like on a Monday, I know that I can start at 9. I just make sure I have the proper time to work with each client. And then I also have the proper time to make sure I notate everything I need to, because that needs to be done within 48 hours of you seeing people. But I am a visual learner. So I write, although I can see it on the calendar, I write things down. I write stuff down that I need to follow back up with clients that I may have met last week and I'm meeting again this week. So I can ensure that either they're doing their homework, or if we have something that we need to follow up and talk about that may have occurred over the weekend that they may have emailed me back about. I don't email them. I wait until the time we meet. So making sure you have the right time to meet with individuals, the proper time to document, and also just set your day up where you know you can maximize it to the best of your ability.
Describe how you can be successful in dealing with Medicaid and other government agencies, the
Ooh,
do's and
Dr.
the
Felicia
don'ts.
Sawyer. um, Now that's the so when I was at the inpatient facility for alcohol or other drugs, I had to work hand in hand with Medicaid and other government agencies. And when I tell you it is discouraging, because when people need help, they are ready to cut them off. Um,
Mm.
and they don't have people qualified. Like they're not, so I'm face to face with these individuals. They're not face to face. All they're doing is taking something that I've um emailed over to them or faxed over to them. They'll have a phone interview with me, and then they'll say, well, we believe that they've reached their maximum potential, which they have not. So it is hard working with Medicaid and other government agencies, because there are a lot of people being bought out. And so it's the rules have become extremely strict for mental health and behavioral health to get paid. Where I'm at now, I don't do billing, thankfully. My the owner, she does all the billing, and she has described how it's like pulling teeth. So it's good. One thing I would tell you is that when you talk to someone and they are helpful, keep that same person's name and number, and that let that be your liaison for Medicaid or any government agency, because that's how you will get your help. It's hard when you're bouncing all around from one person to the next who may not know who do know. So when you get that person who helps you, keep that information.
Oh, okay. And have you ever dealt with clients, children or adults who wanted to commit suicide? And how did you, or which strategies did you use?
Yes, I have. It's uh, it's when sometimes I can't wrap my mind around it. Sometimes I can, but when a child, a teenager, when they are confronting wanting to take their life or lives, they feel like it's better off, which what I normally would do and what we have to do is do an assessment, and it's a suicide assessment, just simply asking them their intent, because if they say it but they don't have a plan, then that's how we measure where they're at. But if they tell you, they, say, Tawana, I want to, I'm contemplating killing myself. And I think I'm going, like, I have a plan in place. I have the gun right here. So that's a whole nother story. If they have a plan, then we have to go ahead, being that we have the duty to warn, we have to call somebody. Um, Either we'll call a parent, but most importantly, if they have a plan and they're sitting there with a gun, we're calling ambulance and the cops to get there. But we do normally with not normally, standard procedures with individuals who have suicidal ideations. We make what we call a safety plan, and that safety plan consists of um, who would help you during this time as far as to talk you off the ledge. Um, we'll name those people. Um, we'll list the resources. That's what is included in the suicide plan.
Oh, okay. Thank you so much. And my last question, how do you maintain your own mind body wellness? Because you work in a very stressful field with all types of people. So, what is your advice to maintain your own wellness?
I am a big advocate of self care. If it means closing the door, turning the lights off, and not talking, turning your phone off, turning everything off, just to have that moment. But I highly encourage anyone in this field to have someone else to talk to. It could be a colleague, it could be your pastor, it could be your mom, your dad. Just have someone else that you can talk to help you process your day. But when it comes to self care, if it's reading a book, if it means go get a mani pedi, if it means to go get a massage, if it means to just dance in your den, do it, because you have to have an outlet for yourself, because people have a lot of issues that are more so um, more challenging than ever before, considering the times that we're living in. So you have to make sure you take care of yourself and that you're able to pour in order to be able to pour into anybody else.
Well, thank you so much, Ms. Hayes. I enjoyed this conversation.
You're welcome. Thank you.